Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, I went ahead and put together a few tangentially related pharmacology topics related to nutrition. In this lecture, we're going to cover vitamins, complementary and alternative medications, as well as weight loss medications. And these are three commonly overlooked issues related to GI pharmacology. As always, you can find all of the notes for this lecture at bulletpointnursing.com. And please support this channel by going ahead and subscribing. This channel, as always, is geared towards nurses, nursing students, as well as students going through their nurse practitioner program or preparing for their nurse practitioner program. So let's go ahead and begin with vitamins. We're going to go through this pretty quick. I think most courses wouldn't get too deep into the actual sources of vitamins and things like that, but let's just hit some of the highlights of each of these vitamins, beginning with vitamin A. Vitamin A is fat soluble. It is teratogenic, and that's its most unique aspect. And probably the most likely thing that you would be tested on is the fact that if taken in high doses during pregnancy, vitamin A can actually be teratogenic. A deficiency in vitamin A can cause night blindness, and it is used for your eye health. Vitamin D is one of the most commonly taken vitamins, and there's two parts to it. Part of it can be taken via supplements, and that's the way we get it in our normal diet through eating foods that have vitamin D. And part of it we actually absorb through our skin from the sun, which, by the way, most sunscreens can block the actual absorption of vitamin D into your skin. So where do we get it? We already said foods that have it, sunlight, and different supplements. Now, when do patients need to take vitamin D? Because this is a really common one. It's any patient who needs to increase their calcium level, or obviously anyone who needs to increase their vitamin D level. Who needs to increase their calcium level? Well, that could be patients taking steroids. That could be patients that are immediately perimenopause or postmenopause. That could be patients that are taking PPIs, because those are known to increase the risk of fractures. So anyone who's in any of those groups, as well as a few others, would be recommended to increase their intake of vitamin D. There are a few different over-the-counter versions of vitamin D, as well as prescription versions as well. And this is also a fat-soluble vitamin. You'll notice I have sorted fat-soluble, and then we'll get into the water-soluble. Vitamin E, not much to talk about it. It is very well known as an antioxidant. If you remember learning about oxygen toxicity, that when we have too much oxygen in our body, that the free radicals, those oxide free radicals, can actually cause damage. So this is along the same lines. It's an antioxidant. It prevents those free radical oxides from causing damage. Vitamin K is something that you're very familiar with if you've watched our lecture on warfarin, because warfarin is a vitamin K antagonist. It blocks vitamin K, but vitamin K, it is found in green leafy vegetables such as spinach and broccoli. This is a more tested on vitamin, again, pretty much just because of the warfarin issue. What do we use it for? We use it to reverse a warfarin overdose, or for someone who's bleeding when they're taking warfarin. It's also used, obviously, for someone who's straight up vitamin K deficient. What is it used for? It's used for clotting. And if you don't have enough of it, you may not be able to clot, causing bleeding. It does have a very interesting black box warning that if it is given IV or IM parenterally, it can cause adverse reactions up to and including death. Vitamin C, I'm not going to say this for sure, but I'm guessing probably the most taken vitamin on this list in terms of supplementing. And we get this from citrus fruits and juices, as all of you are very well aware, apple juice, orange juice, things like that. It has a role in immune health. It has a role in collagen synthesis and many other things. It is most well known and most used for immune health and wound healing, such as patients take it to prevent getting sick, things like that. In terms of really quick, just to go off topic here for a second, in terms of the evidence supporting vitamin C, there is some evidence that taking vitamin C, supplementing with it, does decrease the risk of developing common transmissible infections such as the common cold or influenza. However, some of these studies have been questioned due to the fact that a lot of these studies recruited people that were otherwise healthy anyways, so that it wasn't really clear that the correlation equaled causation. But it is very commonly taken, vitamin C, for the purposes of preventing infection. And a little bit it's taken for patients that are already sick to try to help them heal. Again, the studies do show a little bit of evidence that it does help with preventing illnesses. The studies are a little bit weaker when it talks about healing patients who are actually sick. We are now onto our water soluble, starting with vitamin C. So now let's go through the rest of the water soluble, which are the B vitamins. So we have B1, that's thiamine, and that can be found in fortified grains. This is one of the vitamins that are often deficient in patients that have alcohol use disorder or AUD. Next, we have niacin. Niacin is a little bit interesting because niacin actually used to be used, and in some cases still is, to treat hypercholesterolemia when patients have high cholesterol. However, as of the last few years, and this is being filmed in early 24, however, as of the last few years, I think it was 2 years ago, niacin is no longer recommended for the treatment of hypercholesterolemia, hyperlipidemia, because of the excess side effects, because we have more effective agents, and there might be other reasons as well. But for now, this is just an over-the-counter supplement. This isn't anymore used to treat. This isn't used anymore to treat high cholesterol. However, in going through niacin, let's go through it real quick. If a patient doesn't have enough of it, it does cause what's called pellagra. And again, this is another water-soluble one. Vitamin B6, pyridoxine. This one is actually interesting for the fact that this one is used, and it's actually, as of today, according to UpToDate, it's the first-line pharmaceutical agent for the treatment of nausea in pregnancy, aka morning sickness. When patients have that, obviously we know there are other medications. We have Zofran, we have things like that. We'll talk about ginger in a few minutes. However, pyridoxine or vitamin B6 is the first-line recommended choice for patients that are having morning sickness that need something in order to treat that, because it's very safe and it is effective in most patients. Moving on to vitamin B9, that is going to be folic acid. This is something that is very well known in terms of the OB world, because we know that anyone who is attempting to conceive or obviously is already pregnant should always be supplementing with folic acid. However, keep in mind, and this may be a question on your nursing or APRN exams, in the fact that we want these patients, we want females who are even trying to conceive to start taking folic acid basically as soon as they start trying to conceive. Really, it should be even before that, a month before trying to conceive. They should already be taking it every day, not just to get in the habit of it, but because the body needs it at that very, very early stage of pregnancy. And if it doesn't have it, you can have some really bad effects on the fetus. Vitamin B9 is also used to treat folic acid anemia. Vitamin B12, this is most commonly given parenterally, and we talk about this in our hematology lecture. It's most commonly given via an IM injection once a month. It's cyanocobalamin. However, let's just go through the basics. It is only derived from animal proteins such as eggs, dairy, and meat. For patients who are true vegan, they will need to supplement in order to get this. However, most of the foods that are targeted towards the vegan community does purposely fortify their foods with vitamin B12 to make up for this. However, people should be aware of the fact that if they are going to go to a vegan diet, they make sure they're either supplementing or that the foods that they're switching to are fortified with B12. We talk more in hematology about the difference between patients who have a lack of intrinsic factor B12 versus just lack of dietary intake of B12. And finally, we have ferrous sulfate, which is another word for iron. You may also see folate as, ferrous sulfate, which is another word for iron. And this is a very, very common cause of anemia. One of the most common causes, very well known, iron deficiency anemia. In this case, a deficient patients may be educated to take this, to supplement with this. There's a lot more to know about iron and iron deficiency anemia. However, all of that's covered in the hematology oncology lecture. I'm not going to go over all of it over here as well. In terms of just wrapping up the part about vitamins, RDA, most of you probably already know this, how to read dietary and nutrition labels, at least here in the US. RDA is the recommended dietary allowance. That's when it says, let's say potassium 6 milligrams, and you have no idea what that is, but next to it says 4%. Okay, so that's 4% of my daily intake, or 100%. Let's say if something has 60 milligrams of vitamin C, we know that's going to say 100% of your daily vitamin C. Alcohol use disorder often coexists with patients that have, with the deficiencies in vitamins B1, B6, and B9. That being said, alcohol use disorder, or AUD, can exist with deficiencies in every vitamin, both the water soluble, the lipid soluble, but these are the ones that are most common. And for testing purposes, for those of you that are students, these are the ones you'd be most likely to see on a test. Vitamins are organic compounds. That's just an FYI, in contrast to minerals, which are inorganic compounds. and that includes your calcium, sodium, potassium, etc. Calcium and vitamin D have increased recommendations for patients that are postmenopause, also patients that are chronically taking steroids, chronically taking PPIs like omeprazole, things like that. Again, any patient who's at risk for that decreased bone health. One extra thing I did throw in here before we move on to the CAMs, to the complementary and alternative medications, is TPN, total parenteral nutrition. I really didn't have another good place to put this in all the different pharmacology lectures. TPN contains everything that we need in order to survive, everything that our body normally gets from our dietary intakes, such as amino acids, lipids, proteins, carbs, vitamins, and minerals. This is everything that we need to take in our diet. TPN is used when patients are, let's say, ventilator dependent or for some other reason unable to ingest anything through the GI tract for some period of time. Now, when we're giving this, we are always making a decision. Do we want to feed them through an NG-OG-G tube, or do we want to give them TPN? TPN is usually a more temporary option. This is more so the ICU patient that we're not expecting it to be long-term, because we would much rather, and we actually insist for the long-term, that the patients get their nutrition through their GI system. Even if they can no longer eat, then we put in a NG tube if that's an option, or a J tube, G tube, something, so that the GI system is still working and the body's still using the natural pathways of getting nutrition, such as coming in through the GI tract, even if it's not literally food that we're eating, even if we're giving them a feeding formula. However, TPN, that's where we're through your IV parenterally giving you total nutrition, everything that you need. This should be given through a central line because of the risk of extravasation and the damage that it can cause because of the high sugar content and a few other factors in there. We do want to make sure that these patients are ideally getting this through a central line. Keep in mind, these patients, because we're giving them all their volume, all their electrolytes in this one formula, we need to very closely monitor their weight, their volume status, their overall fluid status. We need to monitor their sugar pretty regularly when they're getting this, as well as all of their other electrolytes. Let's go through a real quick lecture on CAMs. Now, I want to head this off by saying this is a relatively controversial topic. I'm going here with material that's straight out of the textbook. The one I used for this particular point is the APRN textbook written by Elsevier. However, I'm just going through the highlights of these just so that you as an RN or future APRN are able to become familiar with these. I'm not looking for an in-depth insight into these, especially since most of the evidence surrounding these different CAMs are constantly changing and evolving. So I'm not trying to give you a final determination here, just to increase your familiarity with each of them. Ginkgo biloba, if you ever see that, it's taken for mental health and for things like dementia. Per the textbook, again, the textbook that I'm using for this specific section is the Rosenthal and Bertram Advanced Pharmacology textbook written by Elsevier. And the data that they have is that there's no strong evidence to support its use, but obviously there's tons of research ongoing. St. John's wort is something you may very well see on an exam, both RN or APRN, in relation to mental health, because mental health is such a big section in pharmacology. St. John's wort works by increasing our serotonin levels. If you've already studied mental health pharmacology, you know that SSRIs and SNRIs and a whole bunch of others all work in that exact same manner. Therefore, St. John's wort should be very cautiously used if the patient's also taking some other serotonin medication, such as sertraline, paroxetine, fluoxetine, etc. In those cases, it does cause a risk of serotonin syndrome if taken with these other options. It is used for depression and anxiety, mostly for depression. It does have, the evidence does show some benefit in mild to moderate depression. There's really no good evidence to support it being used for major depression. Glucosamine and chondroitin, I'm not 100% sure I pronounced that correctly, but let's go with it. This is used for osteoarthritis. Again, the evidence on this is debatable, but by the American College of Rheumatology, this is not to be a recommended treatment. Ginger root, many of you may be familiar with this. When you were a kid, your mother might have told you when you're nauseous, have some ginger ale. However, so it is used for nausea, vomiting. It's also used for some other pain and anti-inflammatory uses. There is evidence that supports it for motion sickness, and a little bit of supporting it for other uses in nausea as well. However, overall, the evidence is mixed, but from what I've seen and from what your textbook says, there is evidence to support it being used in nausea, certainly in nausea related to motion sickness. And in terms of anything further than that, let's leave it at that for right now. CoQ10 or coenzyme Q10, I'm sure many of you have seen the commercials for this. It is used for patients that have cardiac issues such as heart failure, hyperlipidemia, or hypertension. There is some mixed results with this. There's a lot, I can tell you, a lot of anecdotal evidence that it does work. However, the actual evidence-based practice that we all go by in healthcare has mixed results. So it's not conclusive right now. If a patient wants to do it, they can certainly go for it. If a patient doesn't want to, that's certainly fine as well. We're not going to push it one way or the other because there's no strong evidence one way or the other. Cranberry juice, a very commonly used CAM. It is appropriate to use this for the prevention of UTIs. However, notice for the prevention of UTIs. And evidence does support that, but there's no evidence on the effectiveness in treating UTIs. So I've heard that from patients, and you may have as well. Oh, every time I get a UTI, I drink a gallon of cranberry juice and I feel better. That's fine. That's anecdotal. That's not evidence-based. Evidence doesn't support that, but it does support it for the use in prevention. Keep in mind, just a footnote here, the evidence is almost always based on cranberry juice versus nowadays they do have cranberry juice or cranberry capsules, and the evidence may be different for that. It shouldn't just automatically be transitioned to assume that whatever applied for the juice is going to also apply for the capsules. Probiotics, these are quote unquote good bacteria that are in your gut, and they're used for gut health, GI issues, IBS, things like that. There is tons of research about probiotics, and this is something that most clinicians, not only in gastroenterology, but in primary care and elsewhere, do have pretty strong opinions on one way or the other. However, strictly going by the evidence, up to date, does not give any recommendation one way or the other. At this point, it does specifically say that there's no evidence currently to support using this for any clinical diagnosis. Echinacea is something that many of you may have heard of. It's used for immune health, inflammation, and for infections. It does have, again, some evidence showing that it prevents common cold. But again, this is same as the vitamin C. This is for the prevention, not for treatment, and it's not very strong evidence, but there is some evidence there. It's certainly enough evidence that it would be appropriate for you to go ahead and recommend that for your patients, but it wouldn't be instead of any other actual treatment because, again, this is for prevention, not for actual treatment. Finally, saw palmetto is used very widely for BPH, benign prostatic hyperplasia. However, there is no statistical reliable evidence showing that it does help with that. Some CAMs, and we're going to stop here in terms of the CAMs. Again, a lot of this is controversial. A lot of this evidence is changing day by day, month by month. So make sure before you give an informed opinion that you go ahead and research the most current evidence. Up to date is a great source, and there's lots of other ones as well. This is just meant to give you some basic understanding of these CAMs. There are some CAMs that you should be telling patients not to take. I'm not going to get too deep into those. However, I am going to highlight one of them, which is kava, that should be recommended to not take because it can be harmful. In that case specifically, it can cause severe liver issues. But there are some other CAMs as well that I don't want to go into again because the evidence could be changing. Look it up if you're not familiar with it before making a recommendation to your patient one way or the other. It is important patient education, whether you're RN or APRN. Any patient who's taking CAMs, which let's face it, that's tons and tons of patients today. Make sure they know to only take it as prescribed. Make sure they know to get it from a reliable resource, and make sure they tell their provider. We need to know what is going in their chart. It's no longer, we can say, can you just tell me what prescription medications you're taking? No. Today we're asking them, tell me what you are taking, and please include vitamins, supplements, anything else that you're taking, not only prescription and over-the-counter medications. Finally, for the last section of this supplemental GI lecture, I want to go through weight loss medications. We're going to start with the first one, which is the drug lipase inhibitors, which is orlistat. I want to head off this lecture to begin with by saying, first of all, please make sure that you are educating your patients that diet and exercise is the end-all, be-all of weight loss. It's the healthiest way. It's the least side effect way. It's the best for long-term weight loss. It's the best for patients' heart health, high blood pressure, and everything else beneficial that comes with weight loss. The best way is diet and exercise. There's a famous joke in healthcare. A patient is given a weight loss medication and said, take this every day with diet and exercise and you lose weight. And then the joke continues, or you could just not take the medication, but do the diet and exercise and you'll still lose weight. But let's get into it. The first drug we have here is orlistat. According to most resources that I've looked up, this is considered the least effective of all the pharmaceutical options for weight loss. How does it work? It reduces the absorption of fat of the foods that you eat. It does cause pretty significant GI effects in most patients, and it is the least effective. I think it's at about 2 to 3% weight loss is what this one is gives you, so not the best option. The next one, as of early 2024, this is all the craze right now, is the GLP-1 agonist. This is liraglutide, semaglutide, and a few others. Brand names you may be familiar with are Ozempic is the big one. How does this work? It slows the stomach emptying, which increases the fullness sensation. Another way to put that is it makes you not want to eat because you feel full all the time. If you're not eating, lowers your calorie intake, which lowers your weight. This is also a medication. It's actually a second-line medication for diabetes, as we discussed in our endocrine lecture. What do we use this medication for? It is approved as of 2024 for both weight loss and diabetes. It does carry a black box warning of a thyroid tumor risk. This medication, I'm pretty sure all medications for weight loss are contraindicated during pregnancy. This medication, the most common side effect is going to be GI issues, nausea, diarrhea, things like that. And this medication, along with, again, most weight loss medications, can cause some level of an increased heart rate. In terms of the efficacy of this drug, there is a lot of good evidence right now, and this is FDA approved for weight loss, so that does give a pretty good stamp of approval that this does have good effectiveness for weight loss. In terms of the long-term data, this really became popular for weight loss in just the last few years, and especially in 2023, it really took off for weight loss. So the long-term data is not really out there yet, so I'm not going to get ahead of myself. If you are going to be recommending this as an RN or APRN prescribing it, please make sure and look at the most up-to-date research in terms of that and the best option for your patient. Phentermine, which is available in both phentermine or phentermine with topiramate, which is Topamax, are another option that we have for weight loss. These medications also work by suppressing a patient's appetite. These are do have some sympathomimetic effects, so it boosts your overall calorie burning, your heart rate, it increases your respirations, increases your blood pressure. For all of those reasons, this medication is not meant to be used continuously. It's meant to be used cyclically, let's say 3 months on, 3 months off, something like that. I'm not sure the exact current schedules and the most up-to-date guidelines on that, but it is used cyclically. It is not something a patient could just take for the next year like you could with Ozempic. One thing I forgot to mention with Ozempic, which is semaglutide or the other GLP-1s, is that when these medications are used for diabetes and weight loss, it is 2 different dosages. So just something to keep in mind. Again, I don't cover dosages in these lectures, and the vast majority of universities do not teach or do not test on dosages, whether at RN or APRN level. But just so you know, it is used at different dosages, whether it's being used for diabetes or being used for weight loss. Continuing with phentermine, phentermine is a controlled substance. So this is something that you have to track if you're an APRN going to be prescribing this. Finally, we move on to naltrexone with bupropion. The brand name for this is Contrave. This has an unknown mechanism of action. Naltrexone is something that we actually use for narcotic abuse and actually for alcohol use disorder as well, to help patients get over or get past alcohol withdrawal and narcotic withdrawal. Bupropion, you may be familiar with from our mental health lectures, actually used, that's Wellbutrin, that's actually an antidepressant. But together, these medications do work for weight loss. They don't have any major side effects or adverse effects. You do need to be careful if you're giving this to a patient. A, if they've had opioids in the last 14 days, then you got to wait to start this. And B, if they're already taking Wellbutrin for depression, then also you wouldn't be able to use this. It does have a black box warning that it can increase the risk of suicide and suicidal ideation in children and adolescents. And just a few overall notes about weight loss. Weight loss drugs should not be taken in pregnancy. Already we said it's always should be in combination with diet and exercise, just like antidepressants should always be in combination with therapy. You should expect that if you're assessing a patient who does take a weight loss medication, they may have a higher heart rate. Keep in mind, you'd expect that to go down as time goes on, as they lose that excess weight and their resting heart rate comes down, which is a good thing. And like I already said, in combination with diet and exercise. Thank you so much for watching this video. Here are your references, and have a great day.